देख लिया क्या? शैलेश भाई गायब हो गया क्या? सर मोबाइल में आपको आवाज आ रही है पर जूम में नहीं आ रहा है। एक बार जूम में बात करें। Agnesh, can you hear me?
Yes, sir, I can hear you.
Can you hear Dr. Shailesh voice?
No, sir, I can only hear your audio, sir. No, nobody
Yeah,
else's.
Dr. Shailesh, you are not unable to.
Yes, sir.
Okay, we will start the program. I think he has some technical problem.
Yes, sir.
I request Dr. Nandini madam and Dr. Jha madam to introduce yourself and start the program.
Hi, good evening. Welcome to the session. So, welcome Dr. Agnesh. I'm Dr. Nandini, practicing as a consultant neurologist at Kerala. So, it is okay. Can we start the presentation? Is it okay, Dr. Jarna?
Yes, ma'am. Yes, ma'am. We can start the presentation.
Yes, Agnesh, please introduce yourself and start the program.
Yes, sir. Sir, I'm a third year neurology resident, SVP Hospital. So I'll be presenting a short review of UMN and LMN, anatomy and physiology. Yes, sir. Sir, I would like to start by describing UMN and LMN. Upper motor neurons are above the motor neuron levels, and the same level goes as supranuclear for the cranial nerves. This is the cerebral cortex, subcortical structures, cerebellum, brainstem, and spinal cord. While at the motor neuron level is anterior cell for peripheral nerve, and it is called nuclear level for the cranial nerves. While below the motor neuron, it will be peripheral nerve, roots, plexuses, and nerves, neuromuscular junction, and the muscle. And below the motor neuron for cranial nerves, it will be intranuclear. So we have covered detailed cerebral cortex lobe anatomy and lobar functions in previous lectures. And basal ganglia also we have covered, and cerebellum we have covered. So I'll not be covering those. And I'll be covering the physiology and anatomy of the brainstem, spinal cord, anterior cells, peripheral nerves, especially roots and plexuses, and neuromuscular junction, along with the clinical and anatomical correlation and symptomatology. The upper motor neuron structures in your axis are cerebral cortex, subcortical structures, cerebellum, brainstem, midbrain, pons, medulla, spinal cord, that is the ascending tracts and the descending tracts. Moving on to brainstem, I'll cover the anatomy in brief, a very short review of embryology. We'll discuss rule of four, the cross sections of the brainstem at various levels, brainstem nuclei, the physiology, and brainstem syndromes. During embryological development, as the neural tube develops from the ectodermal folds, the neural tube is divided into dorsal alar plate and ventral basal plate via the sulcus limitans. The sulcus limitans will cause the differentiation of the nuclei, and as the fourth ventricle gradually develops, it results in outfolding of the brainstem. As we can see in this image, the structures which were initially dorsal have now come laterally. The structures mainly during embryological development, the mantle layer, that is the basal plate, gives rise to the motor nuclei, and the dorsal plate gives rise to the sensory nuclei. Hence, the basal plate, which lies medially, gives rise to the motor structures, and the alar plate, which lies laterally, gives rise to the sensory structures. A basic rule of four can be followed in brainstem. The rule of four states that there are four midline structures or median structures beginning with M, and four structures to the side beginning with S. Four cranial nerves in the medulla, that is 9, 10, 12. Four cranial nerves in the pons, that is 5, 6, 7, 8. and 4 cranial nerves above the pons. That is 3 and 4 in the midbrain and 1 and 2 upwards in the which lie separate. The 4 midline structures which start with M are motor nuclei of the cranial nerves, which are also incidentally multiples of 4, 3, 4, 6, and 12. The medial lemniscus, the medial longitudinal fasciculus, the motor pathway, that is the corticospinal tract. And the 4 side or lateral structures are starting with S, the sensory nucleus of the 5th cranial nerve, the spinothalamic tract, spinocerebellar tract, and the sympathetic tracts. As we discussed, 4 cranial nerves. The last 4 lie in the medulla, 9, 10, 11, and 12. The middle 4 also lie in the pons, 5, 6, 7, 8. In the midbrain lies the 3rd and 4th cranial nerve, and optic and olfactory nerves are above the midbrain. This is a graphical representation of the cranial nerves exiting the brainstem. As we can see, the medulla gives rise to 9, 10, 11, 12 cranial nerve roots. The pons gives rise to 5, 6, 7, 8, and the midbrain gives rise to the oculomotor nerve and the trochlear nerve. While the olfactory bulb and the optic nerve they lie anteriorly. This is the rule of 4. The 4 midline structures, motor nuclei of cranial nerves, medial longitudinal fasciculus, medial lemniscus, and motor pathway. These are the 4 side lateral structures: spinocerebellar tract, spinothalamic tract, the sympathetic trunk, and the sensory nuclei of the 5th cranial nerve. The major motor nuclei of the brainstem are the 3rd and 4th cranial nerve in the midbrain at the level of the 3rd cranial nerve oculomotor nucleus lies at the level of superior colliculus. The 4th cranial nerve motor nucleus lies at the level of inferior colliculus. The abducens nucleus lies in the pons, while the hypoglossal nucleus, the motor nucleus, lies in the medulla. The Edinger-Westphal nucleus lies in the midbrain, which is the parasympathetic efferent for the 3rd cranial nerve. The superior salivatory nucleus, the parasympathetic efferent for the 7th cranial nerve, lies in the pons, and inferior salivatory nucleus for the 9th cranial nerve also lies in the pons. While dorsal motor nucleus of vagus lies in the medulla, and trigeminal motor nucleus lies in the pons. Facial that is the special vesicular efferent, lies in the pons. It supplies both motor and sensory and autonomic functions. And nucleus ambiguous, which gives rise to efferents of cranial nerve 9, cranial nerve 10, and cranial root of cranial nerve 11. It lies in the medulla. The sensory nuclei are the mesencephalic root of the 5th cranial nerve, principal sensory nucleus of 5th cranial nerve, nucleus of the spinal tract of 5th cranial nerve, nucleus of the solitary tract, the rostral portion which contains the gustatory nucleus, nucleus of the solitary tract caudal portion which gives rise to the general visceral afferent for the cranial nerves 9 and 10, while the rostral part gives rise for special visceral afferent for cranial nerves 7, 9, and 10, mainly for taste sensation, while the caudal portion is for the general visceral sensations of the vagus and the glossopharyngeal. The cochlear nuclei lie laterally. Special somatic afferents in the pontomedullary junction, and vestibular nuclei also lie laterally for balance and equilibrium. Moving on to major ascending and descending long tracts of the brainstem. The major ascending tracts are medial lemniscus, lateral spinothalamic tract, lateral lemniscus, and medial longitudinal fasciculus. They originate in the nucleus gracilis and nucleus fasciculus, nucleus gracilis and nucleus cuneatus of the spinal cord, and they join the ventroposterolateral nucleus of the thalamus. I'll be covering the spinal cord tracts later in detail. Moving on to descending tracts, that is corticobulbar tract, originates from the motor cortex and terminates at the cranial nerve nuclei. This forms the output for the cranial nerves. The corticospinal tract originates from the motor cortex and terminates in the anterior horn cells of the spinal cord. It forms the cerebral peduncles in the midbrain, the basis pontis of the pons, and the medullary pyramids. The rubrospinal tract starts from the red nucleus and process at the level of the tegmentum of the midbrain and goes to the spinal cord anterior horn cells. The medial longitudinal fasciculus arises from the reticular formation and then decussates, goes onward to the spinal cord. The descending MLF contains the vestibulospinal and reticulospinal fibers, which I'll be covering later in detail. The vestibulospinal fibers are mainly for the reflex head and neck movements in response to visual as well as vestibular stimuli. The central tegmental tract originates from the red nucleus and synapses at the inferior olivary nucleus. Shall I move forward, ma'am?
Yeah, sure.
Yes. Moving on to brainstem syndromes, as we discussed earlier, the rule of 4 will make it very easy to delineate all the brainstem syndromes. The midlines, as we can see, the structures lying medially are the medial longitudinal fasciculus, the medial lemniscus, the ocular motor nucleus, and the fibers of the corticospinal tract, while the structures which lie laterally are the sensory tracts or the ascending fibers from the spinal cord. This is a section at the level of the mid-pons. And I'll start discussing the brainstem syndromes. We start with the midbrain syndromes, that is Carnot syndrome, Weber syndrome, Benedict syndrome, and Claude syndrome. Carnot syndrome, the difference in all 4 of these is the location of the lesion and the structures involved. The Carnot syndrome, the lesion is localized to the midbrain dorsum, and the structures involved are quadrigeminal plate, pretectal, and the periaqueductal brain. This results in, as the third cranial nerve nucleus is involved, the patients will have impaired upgaze, convergence, retraction, nystagmus, and dilated pupils with light near dissociation because of involvement of the pretectal nucleus of the third cranial nerve. Weber syndrome is a lesion of the midbrain base. Here, the structures involved are the infranuclear fibers of the third cranial nerve and the cerebral peduncle. This results in ipsilateral third cranial nerve palsy and contralateral hemiparesis. While Benedict syndrome involves the red nucleus in addition to the above fibers, it also involves the spinocerebellar tract, hence resulting in ipsilateral third cranial nerve palsy, contralateral hemiparesis with ataxia, hyperkinesia, and the rubral tremor. And the Claude syndrome is similar to Benedict syndrome, although the corticospinal tract involvement is minimum to none. It results in similar ipsilateral third cranial palsy, contralateral ataxia, and rubral tremor. The major difference between Benedict syndrome and Claude syndrome is that the rubral tremor is much more prominent. In Claude syndrome, the ataxia and tremor are less compared to Benedict syndrome. And the characteristic of rubral tremor is that it is a low frequency tremor which persists during rest as well as during action. North-Nakel syndrome is the lesion of dorsal midbrain tectum. It has either ipsilateral or bilateral third cranial nerve involvement without any involvement of the other structures or minimal involvement of the superior cerebellar peduncle. This results in third cranial nerve palsy and ipsilateral ataxia. Moving on to pontine syndromes. As per the rule of 4, the medial structures in the pons are the medial lemniscus, the medial longitudinal fasciculus, the motor nuclei of the the motor pathway, that is the corticospinal tract, and in the lower pons there is the abducens nucleus. So in lesions of the pons, especially in Miller-Butler syndrome, there is involvement of the 7th cranial nerve nucleus and the corticospinal tract, resulting in ipsilateral peripheral facial palsy, contralateral hemiparesis. In Fovell syndrome, there is 7th cranial nerve involvement and 6th cranial nerve involvement, resulting in facial palsy, horizontal gaze palsy, contralateral hemiparesis. While Raymond syndrome has 6th cranial nerve palsy and corticospinal tract involvement. This is the section of the medulla at mid-olivary level. As we can see, the structures in the midline or the medial structures are the motor pathway, that is the pyramidal corticospinal tracts, the medial lemniscus, the medial longitudinal fasciculus, the dorsal motor nucleus of the 10th cranial nerve, and the hypoglossal nucleus of the 12th cranial nerve. The lateral structures are the inferior vestibular nucleus, medial vestibular nucleus, inferior cerebellar peduncle, spinal trigeminal tract, spinal trigeminal nucleus, and the ventral spinocerebellar tract. Hence, lesion affecting the midline structures will result in the medial medullary syndromes and lateral medullary syndrome. So lateral medullary syndrome is Wallenberg syndrome. It will involve the lateral structures. the spinal tract of the fifth cranial nerve and its nucleus, resulting in loss of pain and temperature in the ipsilateral face and the contralateral body. There will be a decreased ipsilateral corneal reflex, weakness of the ipsilateral soft palate, ipsilateral gag reflex, and paralysis of ipsilateral vocal cord. Due to involvement of the descending sympathetic fibers, there will be ipsilateral central horner syndrome. And due to involvement of the vestibular afferents, especially the medial and inferior vestibular afferents to the medial and inferior vestibular nucleus, there will be ipsilateral nystagmus. And there will be a ipsilateral ataxia of this ipsilateral ataxia of limbs, cerebral ataxia, and lateropulsion. While a medial medullary syndrome, that is the Nigerian syndrome, involves the medial structures, that is the 12th cranial nerve nucleus, the middle longitudinal fasciculus, the dorsal motor nucleus of 10th cranial, and the hypoglossal nucleus. This results in ipsilateral tongue weakness, contralateral hemiparesis, which spares the face, and impairment of the posterior column function because of involvement of the medial lens space. Shall I proceed further? Hello.
Yes, Ratnesh, you can proceed further.
Yes, short blood supply of the brainstem. It arises from the posterior circulation. The two vertebral arteries combine to form the basilar artery. Before the combination of the two vertebral arteries, it gives rise to the anterior spinal artery and the posterior spinal artery and the posterior inferior cerebral artery. The posterior inferior cerebral artery supplies the medulla and the lower cerebellum. The basilar artery goes on to supply the medulla, the pons and the midbrain. It supplies via the penetrating perforating branches and the circumferential branches. Also, it gives rise to anterior inferior cerebral artery, which supplies the lower and middle pons and the anterior cerebellum, while superior cerebral artery supplies upper pons, lower midbrain, and upper cerebellum. And basilar arteries then give rise to the posterior cerebral arteries, which supply the medial occipital lobe, temporal cortex, subjacent white matter, and posterior corpus callosum and upper midbrain. I'll move on to spinal cord. Initially, during embryological stages of development, the spinal cord is the 31 spinal segments are exactly in line with the 31 vertebral bodies. But as the fetus develops, the vertebral bodies get lower in number and the spinal cord shrinks and moves upwards. At birth, the spinal cord lies at the level of L3, and in adulthood, it lies at the level of L1. The spinal cord extends from the downward continuation of the medulla at the upper border of the posterior arch of C1 to the lower border of L1. The conus medullaris is the bulbous structure at the end of the spinal cord at the level of T12 to L1, while cauda equina is formed from the nerve roots arising from the conus medullaris, that is the L1 to L5, T12 to L1 to L5, and the sacral nerve roots from the cauda equina. The filum terminale is the embryological remnant of the meninges and the spinal cord, and it extends to the coccyx. There are 31 pairs of spinal nerves, and because of the development, the nerves roots exit at different level as compared to the vertebral levels. Moving on to major tracts of the spinal cord, the tracts which we see in ascending tracts are in blue color, while descending tracts are in red color. The major descending tracts are the lateral and anterior corticospinal tract, rubrospinal tract, the descending autonomic fibers, the anterior and the lateral and medial reticulospinal tract that arises from medulla and pons, and the vestibulospinal tract as well as tectospinal tract. While the major ascending fibers are posterior column, which comprises of fasciculus gracilis and fasciculus cuneatus, the dorsolateral tract of Lissa, and the spinocerebellar tract is divided into two parts, that is the anterior spinocerebellar tract and the posterior spinocerebellar tract. The anterolateral system, that is the spinothalamic tract, includes the spinothalamic, spinoreticular, spinomesencephalic, spinotectal, and spinohypothalamic fibers. And spino-olivary tract arises from the input of the joint position proprioception to the anterior horn cells of the spinal cord and relates to the inferior olive and the cerebellum. major ascending tracts are dorsal column, spinothalamic tract, spinocerebellar tract, and spino-olivary tract. The dorsal column system consists of fasciculus gracilis and fasciculus cuneatus. The fasciculus gracilis carry fibers from the lumbosacral region, while the fasciculus cuneatus carries fibers from the cervicothoracic regions. They carry ipsilateral, proprioceptive, vibratory, fine touch synapse at the level of nucleus fasciculus gracilis, and then projects to the decussating fibers to form the middle limbical system of the brainstem. As you can see, the fibers carrying the proprioception, vibration, fine touch, and touch pressure join the fasciculus gracilis for lumbosacral regions and fasciculus cuneatus for the cervicothoracic regions. Ascend upwards, they synapse at the nucleus fasciculus gracilis and nucleus fasciculus cuneatus. Then they decussate and join the medial meniscus system at the brainstem to synapse in the ventroposterior nucleus of the thalamus. And then further forward, they go to the sensory cortex and the sensory association cortex via the thalamocortical connections. The lesions of dorsal column result in sensory ataxia and sensory loss, especially of touch, fine touch, pressure, and paresthesia. The sensory ataxia results in impaired joint position sense, especially when more than 75% of axons stop function, impaired vibration sense, and positive Romberg sign. Because of dorsal column involvement, Kermit's phenomenon can also occur, which is on anterior flexion of the neck, patient has electric shock-like sensation passing from the neck downward towards the spine. This can be seen in multiple sclerosis, SACD, cervical spondylosis, radiation myelopathy, and intramedullary tumors. Moving on to spinothalamic tract. This carries pain, temperature, and crude touch sensation. The spinothalamic tract consists of contralateral projections of second-order neurons, which receive afferent input from dorsal root project via the ventral commissure. They project via the ventral commissure, the contralateral side, after ascending about one level or more. The lesions of the spinothalamic tract result in contralateral loss of pain, temperature, and crude touch. As you can see, the fibers they join at either the same level or one or two spinal cord segments, and then they cross over upwards to the ascending tracts. The fibers of the corticospinal tract, the dorsal column, and the spinothalamic tract are arranged in a somatotopic organization. The fibers, as the uncrossed fibers, the fibers from the dorsal column system, they represent initially the sacral fibers join, followed by the lumbar fibers, followed by thoracic fibers, and followed by cervical fibers. Hence, from medial to lateral, they are arranged as sacral, lumbar, thoracic, and cervical. While the fibers of the spinothalamic tract, they cross and they decussate within the spinal cord either at the same level or one or two segments above, resulting in an inversion of the pattern. Hence, at the level, the arrangement will be sacral, lumbar, thoracic, and cervical. As the fibers add up, it joins together. For the corticospinal tracts, the decussation occurs at the medullary pyramids. After the decussation, the fibers go as the most medial fibers are cervical fibers, followed by thoracic, followed by lumbar, and followed by sacral fibers. Moving on to spinocerebellar tract. The anterior and posterior spinocerebellar tract, the cell bodies of the first am I audible, ma'am?
Dr. Ratnesh, you're not audible.
Ma'am, sorry, I'm having network issues. The network is disconnecting in between.
Now you're audible.
Yes, yes. Uh, and the cell bodies of the first order sensory neurons, which lie in the dorsal root ganglia of the spinal nerves. They enter the posterior horn of the gray matter through the posterior roots of spinal nerves. They relay in the spinal nerves in the nucleus dorsalis, that is the Clark's column. Then these first order neurons, some of them proceed forward as the anterior spinocerebellar tract, while some of them go as the posterior spinocerebellar tract into the inferior cerebellar peduncle and into the cerebellar cortex. They carry mainly unconscious proprioceptive sensations from the spinal cord to the cerebellum and play a role in the muscular coordination. The posterior spinocerebellar tract plays a role in gross limb movements, while the anterior spinocerebellar tract plays a role in fine limb movements. Moving on to spino-olivary tract. These carry proprioceptive information from the tendons and the muscles. They enter the dorsal aspect of the spinal cord and terminate within the dorsal gray matter. And they synapse across the midline to ascend in the white matter at the junction between the ventral and lateral white columns as the spino-olivary tract. As they cross over from one side to the other and back again, they convey the information from the ipsilateral side as related to cutaneous as well as proprioceptive information. So spinocerebellar and spino-olivary tracts both relay ipsilateral information. These are involved in motor learning and coordination. The lesions of spinocerebellar and spino-olivary tract will result in, mainly the lesions of spinocerebellar tracts will result in ipsilateral ataxia of limbs and gait, intention tremor, and dysmetria. And lesions of the spino-olivary tract will result in difficulty with learning and executing skill motor movements. As we discussed, the fibers which cross are the fibers of the spinothalamic tract and medial hemispherical dorsal column medial hemispherical system. They carry sensations from the contralateral side of the body, while for spinocerebellar tract and the cuneo-cerebellar tract and the spino-olivary tract, it is the same side of the body. Shall I proceed forward now? Hello.
Yes, Dr. Ratnesh. We'll discuss
Yes,
in the end, I think.
Yes. The major descending tracts of the spinal cord are corticospinal tract, rubrospinal tract, tectospinal tract, vestibulospinal, reticulospinal tract, that is medial and lateral reticulospinal tract, and the descending autonomic fibers. The corticospinal tract starts from the motor cortex, primary motor cortex, and premotor cortex, and the supplementary motor areas. Then it then it combines to form the corticothalamic, that is the corona radiata fibers. It combines to form the internal capsule. From the internal capsule, it proceeds forward into the midbrain as the cerebellar peduncles. Then it proceeds forwards into the pons and the medulla as the pyramids. And at the level of the pyramids, there is a decussation. The fibers from the right hemisphere cross over and go to the left side of the spinal cord to form the lateral corticospinal tract. 90% of the fibers decussate, forming the lateral corticospinal tract. Only around 10% remain in the same side, which form the anterior corticospinal tract. Although the fibers which have not crossed over will then again cross over at the level of ventral commissure of the spinal cord from the anterior corticospinal tract. They synapse with the interneurons and the motor neurons of the spinal cord. Lesions of the corticospinal tract will result in ipsilateral at the level of spinal cord. The lesions of the corticospinal tract result in ipsilateral paresis, particularly affecting the anti-gravity muscles. That is the flexor muscles of the legs, hip flexion, knee flexion, foot dorsiflexion, and extensor muscles of the arm. That is the deltoids, triceps, wrist extensors, and finger extensors. This results in the particular pattern of spasticity due to pyramidal tract lesions. There is increased tone, increased muscle stress reflexes, and Babinski signs are present. Moving on to other descending tracts. The rubrospinal tract arises from the red nucleus. It crosses in the ventral tegmentum, caudal to the red nucleus. Then it forms the rubrospinal tract and it terminates in the anterior horn cells of the spinal cord. This facilitates the activity of flexor muscles and inhibits the activity of extensor muscles. This is responsible for control of muscle tone and synergy of movements. And disruption of this tract is also responsible for the pyramidal pattern of spasticity. The lateral reticulospinal tract arises from the reticular fibers, the reticular formation, and it continues as the reticulous spinal tract and terminates in the anterior horn cells of the spinal cord. This facilitates extensor muscle tone, especially the trunk and the proximal muscles of the extremities. The medial reticulospinal tract inhibits the above muscle, that is the extensor muscles and the trunk and the proximal muscle of extremities, and it also inhibits the autonomic fibers. While the lateral vestibulospinal tract facilitates anti-gravity muscles, that is the extensors of the trunk and limbs, while the medial vestibulospinal tract influences muscles of upper neck, upper back, the head, and is responsible for vestibulo-colic reflex. The tectospinal tract arises from the superior colliculus. It influences muscles of the upper neck, upper back, and the head, and is responsible for movement of the head in response to visual stimuli. A very short review on the nuclei of the gray matter of spinal cord. They are can be organized as either nuclei groups or as laminae. The laminae 1 has posterior marginal nucleus. Laminae 2 has substantia gelatinosa. 3 and 4 are comprised of nucleus proprius. 5 and 6 are base of the dorsal column. 7 is the nucleus dorsalis or Clark's column, and intermediolateral and intermedial nuclei of lateral horn. 7 and 9 are medial and lateral groups of nuclei of the anterior gray column, while 10 surrounds the central canal is composed of the gray commission substantia gelatinosa centralis. The cell columns of posterior horn are mainly sensory nuclei. They are the first one is a relay. The substantia gelatinosa is a relay nucleus for pain and temperature and modification of the transmission of sensory input. The nucleus dorsalis gives origin to axons which form the posterior spinocerebellar tract. Nucleus proprius contains internuncial neurons for spinal reflexes and second order sensory neurons of ventral spinothalamic tract. The visceral afferent nucleus is a relay nucleus for visceral afferent impulses. The anterior horns have mainly motor nuclei, which supply the muscles of neck, trunk, extremities, diaphragm, and muscles of the neck. The lateral horn is mainly for autonomic functions. Intermediolateral column, that is the ninth nucleus, is for preganglionic sympathetic fibers, and sacral parasympathetic nucleus is for preganglionic parasympathetic fibers. Signs which help us differentiate the origin of weakness. Muscle atrophy is usually absent in early stages of UMN lesions. In late stages of UMN lesions, there can be some atrophy, while in LMN lesions, in the early as well as in the late stages, there is severe atrophy of the muscles. In lesions of muscle, there might be mild atrophy in the initial stages, but in later stages, there can be severe atrophy. Fasciculations are common in LMN lesions, especially with lesions of the anterior horn cell and peripheral nerve. Tone is spastic in UMN lesions because of the disruption of the tracts and the disruption of the impulses which we discussed, and the tone is decreased in the LMN lesions. The weakness distribution is the pyramidal weakness in UMN lesions. That is, it spares the anti-gravity muscles. That is the flexor compartment of the arm, flexor compartment of forearm, the wrist flexors, and the hip flexors and hip flexors and knee flexors. The muscle stress reflexes are hyperactive and Babinski sign is present. In LMN lesions, the distribution of weakness will be as per the structure affected. If it is the anterior horn cell, it will be segmental. If it is a peripheral nerve or a plexus, it will be the structure supplied by the nerve or the plexus. The muscle stretch reflexes are hypoactive or absent in LMN lesions. Babinski sign is absent. Moving on to spinal cord syndromes. The first I'll discuss is complete spinal cord transection or transverse myelopathy. In here, all ascending tracts of the spinal cord from below the level of lesion and all descending tracts from above the level of lesion are interrupted. Therefore, all motor and sensory functions below the level of spinal cord damage are disturbed. This section is often incomplete and irregular, especially in non-traumatic causes, and the findings will reflect the extent of damage. A short segment lesion will be less than 3 spinal segments, while a long segment lesion will be more than 3 spinal segments. All sensory modalities are impaired below the level of lesion. Pain, touch, crude touch, vibration, joint position, proprioception, all will be impaired. While a pinprick loss below a segmental level is most valuable for localizing the lesion. Sometimes there might be a band-like or radicular pain or segmental paresthesia at the level of lesion. A localized vertebral pain, especially over vertebral spinous process, or accentuated by palpation and vertebral percussion, favors a destructive lesion, especially infections or tumors. Pain which worsens when recumbent and is improving on standing or sitting is common with malignancy. Moving on to motor symptoms. Below the level of lesion, patient will have paraplegia or quadriplegia. Paraplegia if it is affecting the dorsal or the lumbar spinal cord. Quadriplegia if it affects the cervical spinal cord. Initially, the patient will be in a stage of spinal shock. The tone will be flaccid and areflexic. Later on, it becomes spastic and hyperreflexic. There is extensive plantar response. And there is loss of superficial reflexes. As the disease progresses, there will be extension at hip and knee with incomplete or high spinal cord lesions. And for complete and lower lesions of spinal cord, there will be flexion at hip and knee. At the level of lesion, we can see paresis, atrophy, fasciculations, and areflexia and a segmental distribution because of damaged anterior horn cells or the damaged ventral roots of the spinal cord. In brief, spinal shock, there are four phases of spinal shock: phase 1, phase 2, phase 3, and phase 4. Phase 1 is day 0 to day 1. Phase 2 is 1 to 3 days. Phase 4 is 1 to 4 weeks. Phase 3 is 1 to 4 weeks, and phase 4 is 1 to 12 months. In phase 1, there will be a stage of spinal shock, that is areflexia or hyporeflexia. There is a loss of descending facilitation, because of which there will be no human signs. Gradually, the denervation supersensitivity causes initial reflex return. And as the axons regrow, there will be initial hyperreflexia. Once the cell bodies start to regrow, there will be a final hyperreflexia. In day 0, that is the acute stage, the supraspinal inputs, that is the vestibulospinal and reticulospinal pathways, are interrupted. Hence, it results in hyporeflexia. If the lesion is below the midpoints, there will be hyporeflexia. If the lesion is above the midpoints, there will be decerebrate rigidity. Caudal to the spinal cord injury, there will be loss of tonic descending facilitation to the gamma motor neurons, which results in reduced muscle spindle excitability and less segmental input to the motor neurons by stretch reflex afferents. At day 1 to 3, the cutaneous reflexes start to become stronger, starting with the cremasteric reflex, anal ring reflex. They start to become stronger. The DTRs are still absent. Initially, the first reflex to start to become stronger is the bulbocavernosus, followed by anal ring, followed by cremasteric. In elderly subjects, DTRs and Babinski sign can occur during this phase. It is likely that there might be some pre-existing subclinical myelopathy as a result of degenerative disc changes or degenerative cord changes. Children begin to recover deep tendon reflexes early as 3 days following the injury, perhaps because the descending supraspinal tracts in children are not fully developed compared to adults, thereby predisposing to the spinal hyperreflexia. Phase 3, that is 4 days to 1 month, most deep tendon reflexes appear during this period, and they are evident in almost all subjects within 1 month. The ankle jerk appears first and becomes hyperreflexic, followed by the knee jerk, followed by Babinski, followed by cutaneous reflexes. Phase 4, the delayed plantar reflex disappears. The cutaneous reflexes and DTR and the bulbous cavernous reflex still become hyperactive and respond to minimal stimuli. These are the theories of recovery from spinal shock. Below the level of lesion, there will be bladder and bowel dysfunction, especially if the lesions are bilateral. And these lesions may also cause orthostatic hypotension. Urinary urgency is common. In later stages, there is urinary retention, while in very late stages, there is urinary incontinence. Constipation is the most common bowel symptom. Initially, the bowel and bladder are atonic, and later on, the spastic rectal and bladder sphincter dysfunction occur with lesions at any spinal line. There can be anhidrosis, trophic skin changes, impaired temperature control, vasomotor instability below the level of lesion, and sexual dysfunction may be present. If there is a lesion involving the cell bodies of the preganglionic sympathetic neurons in the cervicothoracic cord, this may result in an ipsilateral Horner syndrome. And especially in patients with high cervical and high thoracic, that is above T6 level spinal cord injuries, they will have autonomic dysreflexia, That is fluctuating blood pressure, severe arterial hypertension, headache, visual impairment. There might be profuse sweating, cutaneous vasodilation as a result of autonomic dysreflexia. Causes of transverse myelopathy or complete cord syndrome is trauma, prolapse of intervertebral discs, metastasis, paraneoplastic myelopathy, structural causes, that is extradural extension of mediastinal or thoracic lesions, myelitis, short segment, long segment, MS, NMO disorders, MOG, spinal cord ischemia, spinal epidural hematoma, spinal epidural fistula, spinal epidural abscesses, autoimmune disorders, and other inflammatory disorders. Parainfectious or post vaccinal causes may also result in a transverse myelitis. Moving on to Brown-Séquard syndrome. In Brown-Séquard syndrome, there will be ipsilateral at the level of lesion, there will be loss of all sensation ipsilaterally. And below the level of lesion, ipsilaterally, there will be paralysis, loss of pain, and there will be loss of proprioception and vibration sense. While on the contralateral side, there will be loss of pain and temperature and weakness. Sorry, man, there will just be a loss of pain and temperature. There is ipsilateral spastic weakness with hyperreflexia and Babinski sign, ipsilateral vibratory or proprioceptive loss due to disruption of the dorsal column fibers. Tactile sensation may be normal or minimally decreased. Contralateral pain or temperature is 1 to 2 segments below the level of the lesion due to disruption of the spinothalamic tract. Segmental element signs, that is segmental weakness and atrophy, and sensory sign, that is segmental anesthesia at the level of lesion, are due to damage to the anterior horn cell and the dorsal rootlets. There might be ipsilateral loss of sweating caudal to the level of the lesion due to involvement of the sympathetic fibers. And as we discussed earlier, ipsilateral Horner syndrome if the lesion is cervical. If the lesion is high cervical due to involvement of phrenic nerve, there might be hemidiaphragmatic paralysis as well. Causes of Brown-Séquard syndrome are stab wounds, blunt trauma, herniated cervical disc, post-traumatic arachnoiditis, chiropractic manipulation, metastatic or primary tumors, MS, other inflammatory and infectious causes, cord ischemia, epidural hematoma, and other vascular causes, and spinal cord herniation. The damage usually starts centrally and then spreads centrifugally to involve the other spinal cord structures. This is usually chronic. Acute atypical presentations are rare. There is interruption of the crossing fibers of the spinothalamic tract near the ventral commissure, which results in a dissociative sensory loss at the level of lesion. And this may also result in a band-like sensation, generating the so-called suspended sensory level, which can be seen in syringomyelia. If the central cord lesion is larger or with forward extension of disease process, the anterior horn cells become involved at the level of lesion, resulting in segmental neurogenic atrophy, paresis, and areflexia, that is the man-in-barrel syndrome. As the lesion extends laterally, there will be ipsilateral Horner syndrome, kyphoscoliosis, and later on spastic paralysis below the level of lesion. As the lesion extends dorsally, there will be involvement of the dorsal column, and extreme ventrolateral extension will result in involvement of the spinothalamic tract. There is sacral sparing because the lamination of the spinothalamic tract involves, because of the lamination of the spinothalamic tract, if the lesion extends from the center and progresses forward towards the periphery, the sacral fibers will be spared until the end, while in the end of the disease, it might be involved. As we discussed, the man-in-barrel syndrome, the flaccid paralysis at the level of lesion, ipsilateral spastic monoparesis, and loss of pain and temperature at the level of lesion, that is dissociated sensory loss. Common causes are trauma, fracture dislocation, compression fracture, syringomyelia, hydromyelia, hematomyelia, and intramedullary spinal cord tumors. Moving on to anterior cord syndrome, it has 4 essential features. The structures anteriorly in the spinal cord are the the ventral uncrossed corticospinal tract, the vestibulospinal, ventrometiculospinal, and tectospinal tract, and some part of the lateral corticospinal tract. This results in quadriplegia or paraplegia, impaired bowel and bladder control, loss of pain and temperature sensation because of involvement of the spinothalamic tract, and sparing of position sense, vibration sense, and light touch. This is most commonly seen in anterior spinal artery infarcts. Although This is more frequently seen in the watershed or boundary zones, that is the mid-thoracic region, T3 to T8. Posterolateral cord syndromes are a combination of the dorsal column and corticospinal tract dysfunction. Bilateral UMN weakness is there below the level of lesion with decreased vibratory and position sense, but sparing of pain and temperature sensation. There is sensory ataxia with positive Romberg sign and bladder atony. The ankle reflexes may be lost or become hypoactive early in the process because of superimposed peripheral neuron. Below the level of the lesion, patient will have spastic paraparesis, loss of position and vibration sense, and clinical signs of sensory ataxia, that is Romberg sign, and loss of vibration and position sense. Common causes are SACD, extrinsic spinal cord compression, nitrous oxide myelopathy, copper deficiency, HIV-associated vascular myelopathy, HTLV-associated tropical spastic paraparesis, copper deficiency, adrenomyeloneuropathy, methotrexate toxicity, spinal epidural fistula, lathyrism, and conzo. If there is selective dysfunction of posterior column, the causes are further narrowed down. Tapes dorsalis, posterior spinal artery infarction, as it supplies the posterior 1/3 of the spinal cord. MS, partial cord trauma, and after platinum-based chemotherapy. Moving on to blood supply of the spinal cord. It is supplied by the single unpaired anterior spinal artery and the two paired posterior spinal arteries, which arise from the vertebral arteries and they descend downwards. Also, it is supplied by the segmental branches from the intercostal arteries, anterior radicular branch and the posterior radicular branches. The anterior spinal artery and the radicular arteries supply the anterior 2/3 of the spinal cord, while the two posterior spinal arteries supply the posterior 1/3 of the spinal. The various types of spinal cord ischemic syndromes are anterior spinal artery syndrome, posterior spinal artery syndrome, lacunar infarctions, hypoxic myelopathy, spinal cord claudication due to hemodynamic PIAs, venous infarctions, lesions due to dural AVFs and AVMs, and intramedullary hemorrhage. The spinal cord infarction usually occurs in the watershed or boundary zones, where the major arterial system supplying the spinal cord anastomas at their most distal branches. These watershed zones are T1 to T4 segments and the L1 segments. Anterior spinal artery syndrome will have back or neck pain of sudden onset and rapidly progressive hyperacute flaccid and areflexic paraplegia, loss of pain and temperature with a specific sensory level, and preserved vibration and proprioception sense because of sparing of dorsal columns. There might be urinary incontinence and there might be painful burning based aesthesias. In posterior spinal artery syndrome, there will be involvement of the posterior column, resulting in loss of proprioception and vibration, preservation of pain and temperature, except for the involved level of the spinal cord, and loss of cutaneous reflexes and DTR below the involved segment. If there is the interruption of decussating pyramidal tract fibers at the cervicomedullary junction, it might cause a foramen magnum syndrome, which may present as cruciate paralysis or hemiplegia cruciata. Cruciate paralysis is bilateral paralysis or paralysis of just the upper extremities without significant involvement of lower extremities. While hemiplegia cruciata is spastic palsy on the ipsilateral side of the upper extremity with spasticity on the contralateral side of the lower extremity. Along with that, there might be the Ehrlich's phenomenon, that is the round-the-clock pattern of weakness. The weakness might affect the left lower limb first, after that left upper limb, followed by right upper limb and right lower limb. A round-the-clock pattern may be present. Along with that, there might be downbeat nystagmus, papilledema, and cerebellar ataxia. If there is a lesion before the crossing of the corticospinal tract, it will result in contralateral hemiparesis. At the crossing level, if the fibers for the upper limb are involved preferentially, it will cause hemiplegia cruciata. If the fibers for the lower limb are involved preferentially, it will result in paraplegia. While after the crossing, if the fibers are, it causes ipsilateral hemiplegia. I'll briefly cover compressive myelopathies, extramedullary, extradural, extramedullary, intradural, and intramedullary. These are the various causes for the same. Acute causes are vascular disc prolapse, trauma, hyperextension injury, and antiphospholipid syndrome and other hypercoagulable states. While chronic are disc lesions, cervical stenosis, lumbar stenosis, tumors, Paget's disease, and osteoporosis. Extramedullary intradural lesions are meningioma, neurofibroma, and leptomeningeal metastasis. And intramedullary lesions mainly are syringomyelia, hydromyelia, intramedullary AVM, SOL such as tuberculoma or NCC, and tumors such as glioma, astrocytoma, and ependymoma. These are differences for extramedullary versus intramedullary. Radicular pain is unusual in intramedullary lesions, while it is very common and may occur early in extramedullary lesions because of involvement of the nerve root or the fibers from the nerve root. Vertebral pain is common in extramedullary syndromes. Funicular pain is common in intramedullary spinal cord syndromes. There is sacral sparing until the late stages because the sacral fibers lie most laterally. While as the sacral fibers lie most laterally, there is an early sacral sensory loss. There are early UMN signs in the extramedullary lesions, and the element signs are unusual. And if present, they might be segmental because of the dorsal root ganglion involvement, while element signs are prominent and diffuse, especially at the level of the lesion. The progression of paresthesia is ascending in extramedullary lesion and it is descending in intramedullary. The sphincter abnormalities are early as the sympathetic fibers are involved early on, and there is a late involvement of the sphincter in extramedullary spinal cord syndromes. Moving on to conus medullare syndrome and cauda equina syndrome. Conus medullare syndrome is the involvement of the spinal cord at the level of T12 to L1, and cauda equina syndrome is the involvement of the nerve roots from N1 to L5 and the sacral and coccygeal nerve roots. And as we discussed earlier, the caudal end of the adult spinal cord is situated at the level of first or second lumbar vertebra because following the third month of fetal development, the vertebral column grows faster than the spinal cord. The nerve roots elongate and extend past the caudal end of the spinal cord to form the cauda equina. This caudal end tapers off into the cone-shaped conus medullaris and continues distally as phylum terminal. The epiconus is L4 to S2 segments. Conus is S3 to S5 segments, and the coccygeal segments. And cauda equina is the nerve roots of L2 to L5, S1 to S5, and the coccygeal nerves. To differentiate conus medullare syndrome, we can differentiate them on basis of presentation. The presentation of conus medullare syndrome is usually sudden and bilateral, while it might be gradual and unilateral in cauda equina. The reflexes, knee jerk is preserved, but ankle jerks are affected in conus medullaris, while in cauda equina, ankle jerks will be absent. The radicular pain is less severe in conus medullaris, and in cauda equina syndrome, it is more severe, asymmetric, and worse at night. The low back pain is more severe in conus medullaris syndrome and less severe in cauda equina syndrome. There is a bilateral and symmetrical saddle anesthesia and perineal numbness in the conus medullaris syndrome, and the numbness is more asymmetrical in perineal area in the cauda equina syndrome. And there might be specific dermatomal loss of sensation, especially in the lower limbs. There is asymmetric and areflexic paraparesis and marked atrophy in cauda equina syndrome, and there is a symmetric hyperreflexic distal paresis of lower limbs, which is less marked. Common and early bowel, bladder, and sexual dysfunction noted in conus medullaris, while bowel, bladder, and sexual dysfunction are less common late in cauda equina syndrome. These are etiologies of cauda equina syndrome. Due to structural spinal disease, vascular, neoplastic, inflammatory, infectious, iatrogenic, and other causes. Common causes of conus medullaris syndromes are due to lumbar canal stenosis, due to traumatic vertebral body fractures, traumatic spondylosis and spondylolisthesis, vertebral body tumors, intrathecal and extra medullary tumors, intramedullary tumors, and spinal cord AV malformation or the spinal dural AV fistula. And moving on to the peripheral nerves at the plexus level, I'll discuss
Dr.
the brachial
Ratnesh?
plexus and the lumbar plexus. Yes, ma'am. Yes, ma'am.
Nandini ma'am, do you want to ask questions on UMN first and then we'll go to LMN? Is that fine?
Yeah, that is fine. I think the topic is really very vast. He has done a fantastic job.
And
Yes,
he has
ma'am.
covered
Cover-
everything.
Yeah, to cover everything, it is really difficult. I think we can finish. We can edit first the UMN part, then we'll go to the rest of the things.
Okay, ma'am. Okay, ma'am. No issue.
So, okay, so yeah, you have told very excellent about the brainstem structures, the rule of four, and other things. So yeah, the important thing what you have to know, the as you said, the supranuclear is above the nuclear level for the cranial nerves and above the anterior horn level for the peripheral nerves. All those things consist of the supranuclear structures. So it starts from the corticobulbar tract as well as in the all the spinal tracts. So all the
Yes, ma'am.
arrangements and laminations you have detailedly described. Uh, one more thing extra what I have to add is you must know like the rule of 17 and other things, the deviation of one side to deviation of other side, so that examiners will be very keen on knowing that. And how is the
Yes, ma'am.
innervation, like crossed innervation or ipsilateral innervation to the supranuclear level of the cranial nerves. So every nuclear get bilateral innervation. So what is that except? How is that? What is the central facial palsy and what is the mimic facial palsy?
Yes, ma'am.
Those things you must be aware of. And why is the same side deviation for this 12th nerve and 5th nerve, and why is the opposite side deviation for the 7th nerve and 10th nerve? Those things you have to know.
Okay.
And the
Yeah,
the
and
one
then intraaxial versus extraaxial differences you should know in cranial nerves. So,
Okay.
if say suppose for oculomotor, what will be the features which are intraaxial? Say suppose a lesion
Okay.
is intraaxial or extraaxial. Do you want to answer that?
Ma'am, interaction lesions might cause supranuclear or nuclear involvement of the cranial nerves, while extraction lesions usually cause infranuclear involvement of the cranial nerves.
Yeah, especially in oculomotor nerve, you'll look for opposite eye superior rectus because they cross internally.
Yes.
Yeah. So just all for all cranial nerves, you should know intraaxial versus extraction. And there will be
Okay.
bilateral ptosis, correct?
Yes.
Yeah. Nandini ma'am, you were saying, I'm sorry.
that's okay. And this trochlear nerve as well, it will goes to the opposite side for its supply. So if there is a lesion, false localizing signs,
Yes. Yes.
supranuclear level. Yeah. Why
Yes.
is that? Because of
Long
the long
intracranial course of
travel,
the
yeah,
fourth
intracranial
nerve. Yes.
travel and other things.
Yes.
And yeah, since there is a pyramid formation, the ipsilateral lesion will cause a contralateral hemiparesis and other things of the CST, of the corticospinal tract. But there are also some condition where there can be ipsilateral hemiparesis. One is so those are also the false localizing sign of raised ICT and other things. When there is a
Yes, ma'am.
ipsilateral compression, herniation over the midbrain regions and other things. So those things also must be known.
Yes.
Anything else, Dr. Janama?
Um, you describe the reticulospinal and vestibulospinal. So you
Yes,
just
ma'am.
want to summarize what does the lateral reticulospinal does and what does medial reticulospinal does?
Ma'am, the medial reticulospinal is mainly for maintaining the upright posture of the body. That is the extensor muscles of the back and the extensor muscles of the neck.
Okay.
And I'll come to this slide. And
And they arise from basically pontine reticular
ma'am,
formation.
yes, ma'am, medullary and the pontine reticular formation.
Yeah, and lateral will arise from the medullary.
Yes, ma'am.
Yeah. Which one is ipsilateral? Which one is contralateral?
The lateral radicular, so reticulospinal tract is ipsilateral. The medial is contralateral.
Yeah. Similarly, vestibulospinal also there's medial and lateral. So which is responsible for head and neck posture?
Ma'am, medial vestibulospinal tract is responsible for the head and neck posture and the vestibulocolic reflex.
And then lateral will increase the extensor or the flexor?
Ma'am, anti-gravity muscles, extensor muscles of the trunk and
Extensor.
limbs.
Correct. Correct. Yeah. So you've covered that. You've covered almost everything. So, ma'am,
In this, I also wanted to tell you about the paraplegia and flexion and extension. You must
Yes,
be
ma'am.
also aware of that. So,
Yes,
when
ma'am.
that occurs, when there is a complete spinal cord lesion, what will be the uh, attitude of the patient? Like, will it be in paraplegia and flexion or extension? Or if there is an
Ma'am, in
incomplete spinal cord, proceed.
uh, ma'am, in higher cervical level lesions and in more complete lesions of the spinal cord, there will be paraplegia and flexion. And for lower, somewhat lower and the incomplete lesions, there will be paraplegia and extension.
Yeah, why is that?
Uh,
Because of that arrangement. Now you described, right? Yeah.
yes,
So
yes,
when
ma'am.
those tracks mainly when there's an incomplete spinal cord lesion, the extensors or the last to get affected. So if that is the
Yes,
case, the patient will have a good prognosis, at least for the recovery and other things. But if there is a
yes,
complete loss, the spinal reflex itself will take over its action. It will become to its old primitive reflex. That is how the flexors will start full working. So the attitude of the
yes,
patient will be complete paraplegia and flexion. So that has little bad and poor prognosis. There will be mass reflex and other things. So
yes, ma'am.
these arrangements you have to know so that the clinical applications also you must know.
Yes, ma'am.
And the differences between the intramedullary, extramedullary lesions. I think you have told that, no?
Yes, ma'am.
Okay. So why is that dissociative sensory loss?
And because the fibers of the spinothalamic tract cross via the anterior commissure to the other side, 1 to 2 segments above the lesion. At the level of the lesion, there will be involvement of the dorsal column, and on the other side, ma'am, there will be loss of pain and temperature. This will result in a dissociative sensory loss.
No, no, at one level there will be a loss of pain and temperature, but there is a sparing of dorsal column sensations. So
Yes,
that is what you call a segmented sensory loss because of the lamination. Like the first will be the uh, SLTC arrangement and CTLS arrangement of the ascending and descending tracts.
yes,
And you told about the phenomenon, right? Is it Ellsberg phenomenon or Eldridge phenomenon?
yes, ma'am. Sorry, it's Ellsberg phenomenon.
Yeah, it's Ellsberg.
Was
That is
mistaken.
also
Yes,
it is due to it's the U shape, inverted U shape, due to the lamination and the slow ischemic loss of the tracts.
yes,
And the artery, it is a single anterior spinal artery which is supplying the bone,
yes.
but there is I mean, posterior side is supplied by
Two
both
posterior
two
spinal arteries.
posterior. Yeah, so that is why
Yes,
anterior is most commonly affected. Even if posterior is affected, you will get some watershed supply.
yes,
Yeah, they all originate from the vertebral arteries. And
yes.
you must be also aware of the artery of Adam Chris. That is the watershed artery.
Watershed arteries.
The area you told, right? T3 to
Yes,
T8.
ma'am.
The
Yes.
main artery which is supplying is artery of Adam Chris.
Adam Kiewicz. Yes, ma'am.
And also about the cauda conus, you have discussed well. And what you have to know is chorda is more, it behaves more like an element lesion, asymmetric, areflexic, hypertonic, and other things.
Yes, ma'am.
So the corners will behave more of like a UMN type. Also, you will get an preserved reflexes when extensor plantar and other things.
Yes.
Okay. Anything else to be added, ma'am? Dr. Jemma?
I think we can go ahead, ma'am. Yes, covered everything. Yeah, there's a question, ma'am. Can you discuss about epiconus?
Yeah, we have this. We have told right that epiconus level starts from L4 to S2.
Yes, ma'am.
It is all. It is all the embryology. Like for certain people, the ascending and descending levels varies. So when there is a lesion at L4 to S2, again it will mimic like a conus lesions only. But when the level of involvement varies, we call that as epiconus. Sometimes there can be absent ankle as well as knee reflexes when it involves the epiconus level also.
Yes, ma'am.
Also the sensory levels.
Yes, ma'am.
Okay, I think you can proceed.
Yes, ma'am. I'll discuss brief about the brachial plexus. The components of brachial plexus are 5 roots from C5 to T1. Three trunks, that is upper, middle, and lower trunk. 6 divisions, 3 anterior and 3 posterior. 3 cords, that is lateral, posterior, and medial, and 5 terminal branches. Uh, in some patients, the brachial plexus might be prefixed or postfixed. That's why C4 and T2 have been kept in this diagram. Mainly in most of the patients, brachial plexus forms from the C5, C6, C7, C8, and T1 nerve roots. The branches which arise from the roots are the phrenic nerve, which arises from C5, supplies the diaphragm. The dorsal scapular nerve, which arises from C5 root, supplies the levator scapulae, the rhomboid major and rhomboid minor. The long thoracic nerve, which arises from C5, C6, and C7 nerve roots, it supplies the serratus anterior. The nerve to scalene and longus colli arises from C5, C6, C7, C8 nerve roots. And first intercostal nerve supply arises from this T1 nerve root. Moving on to trunks, the names are given in relation to each other. The superior, middle, and the inferior trunk, or upper, middle, and lower trunk. The upper trunk is formed from combination of C5 and C6. C7 alone gives rise to middle trunk, and C8 and T1 combine to form the lower trunk. The branches which come from the trunks are the nerve to subclavius and the suprascapular nerve. After that, each gives anterior and posterior divisions. These divisions are formed behind the clavicle. Uh, it, it helps the clavicular. It helps in the localization of the lesion, whether it is supraclavicular lesion or infraclavicular lesion. If the nerve roots are if the lesion is above the clavicle, it is more likely to be a trunk or a root lesion. If it is below the clavicle, it is more likely to be a lesion of the division or the branches. The anterior division from the superior trunk combines with the anterior division of the middle trunk to give rise to the lateral cord. The posterior division of all 3 trunks combine to form the posterior cord, and the anterior division of the inferior trunk moves forward as the medial cord. The branches from the cords are in relation to the second part of axillary nerve. Lateral cord gives rise to lateral pectoral nerve, musculocutaneous nerve, and lateral head of the median nerve. The posterior cord gives rise to subscapular, thoracodorsal, axillary, and radial nerve. And the medial cord gives rise to medial pectoral, medial brachial cutaneous and medial antebrachial cutaneous branches, and ulnar nerve and medial head of the median nerve. This is in relation to the axillary nerve, lateral cord, posterior cord, and medial cord. The terminal branches are musculocutaneous, axillary, radial, median, and ulnar nerve. A short review on upper trunk brachial plexopathy sensory loss. This will correspond to the sensory distributions of the axillary nerve, lower lateral cutaneous nerve of the arm, the lateral cutaneous nerve of forearm, lateral antebrachial cutaneous nerve, as well as the median and radial sensory branches to the index finger and thumb. And the motor weakness will be affecting almost the whole upper limb, weakness of the weakness at shoulder, arm, forearm, and at the wrist, as well as the weakness of the small muscles of the hand. Brachial lower trunk brachial plexopathy sensory loss will be mainly involving the inner aspect of the hand, forearm, as well as the arm, involving the medial cutaneous nerve of arm, medial cutaneous nerve of forearm, and the medial aspect of the hand. This is the major muscles responsible for the movement of head and neck, mainly supplied, the sternocleidomastoid and trapezius are supplied by the 11th cranial nerve, that is the spinal accessory nerve. The small muscles of the neck, that is scalenus, anterior, medius, posterior, longus capi, longus chordae, are supplied by the cervical segments. C1 gives rise to the small muscles which are responsible for the yes-no movements of the head and neck. And most of the neck muscles are supplied by the cervical segments, that is C1 to C8, while sternocleidomastoid and trapezius are supplied by cranial nerve 11. I will not go in further detail. This will be too extensive. The extensors of the arm and the extensors of the forearm and extensors of the arm are mainly supplied by the radial nerve. The median nerve supplies the muscles of the forearm as well as the ulnar nerve, and the muscles at the shoulder are the trapezius supplied by cranial nerve 11, levator scapulae, rhomboid major, rhomboid minor supplied by dorsal scapular nerve, serratus anterior supplied by long thoracic nerve, deltoid by axillary, teres minor by axillary, supraspinatus and infraspinatus by the suprascapular nerve, while latissimus dorsi by the thoracodorsal nerve. Moving on to lumbosacral plexus. For brachial plexus and lumbosacral plexus, the etiology both are somewhat similar. Structural causes, because of the fractures or because of avulsion of nerve roots due to trauma or road traffic accident. There might be hemorrhage, or there might be fracture involving the clavicle or fracture involving the shoulder joint. For lumbosacral plexus, it is retroperitoneal hemorrhage due to anticoagulation or due to hemophilia, pelvic or abdominal tumor, common or internal iliac artery aneurysm, endometriosis, and trauma. While non-structural causes are inflammatory, plexitis, plexopathy due to diabetes, radiation, post-surgical, or it might be due to postpartum or due to infarction of the nerve roots. The lumbar plexus can be divided into upper and lower lumbar plexus. Upper lumbar plexus is formed from the L1 to L4 nerve roots. T12 gives rise to subcostal nerve and iliohypogastric nerve, which is combination of the posterior division and anterior division of T12 and anterior division of L1. The anterior rami of L2, L3, and L4 divide into anterior and posterior divisions. The three posterior divisions unite to form the femoral nerve, which supplies the iliopsoas, pectineus, sartorius, and the quadriceps, that is for hip flexion and knee extension. While the sensory branches innervate the medial calf, the anterior medial thigh, and the intermediate cutaneous nerves of thigh. These were the posterior divisions which combine to form femoral nerve. The anterior divisions combine to form the obturator nerve. Obturator nerve, as the femoral nerve supplied the knee extensors and the hip flexors, the obturator will supply the medial compartment, that is the thigh adductors, adductor longus, adductor brevis, adductor magnus, and gracilis, and a small area of skin on the medial thigh. The iliohypogastric and ilioinguinal nerves supply the internal and transverse oblique muscles, and they supply a small strip to the anterior lower abdomen and to the inguinal ligament, rostral medial thigh, upper part of the scrotum in males or labia in females. The genitofemoral nerve is derived from both L1 and L2 nerve roots. It divides into a genital branch and a femoral branch at the level of medial inguinal ligament. This provides a muscular innervation to the cremasteric muscles in males and sensation to the skin over the lower part of scrotum or labia in females. It also supplies the skin over the femoral triangle. The lateral cutaneous nerve of thigh is a pure sensory nerve arising from the L2 and L3 nerve roots. This then divides into an anterior and a posterior branch which supply a large oval area of skin over the lateral and anterior thigh. The sciatic nerve arises from L4 to S3 roots. It provides muscular innervation to the knee flexors, that is the hamstrings, semimembranosus, semitendinosus, long and short heads of biceps femoris, the lateral division of adductor magnus, and all muscles innervated by the peroneal and tibial nerves. The knee flexors, a small part of adductor compartment, and all the muscles of the leg, that is the peroneal and tibial nerve, are supplied by the sciatic nerve. Sensory innervation is provided to the entire lower leg below the knee, with exception of the medial calf, which is innervated by the sternum. The superior gluteal nerve arises from L4, L5, and S1. It supplies muscular innervation to the muscles for hip abduction and internal rotation. That is tensor facial artery, gluteus medius, gluteus minimus. It usually does not have any sensory fibers. The inferior gluteal nerve is derived from L5, S1, and S2. Supplies only the gluteus maximus muscle for the hip extension, while the posterior cutaneous nerve of thigh is a pure sensory nerve, just to supply sensation to the lower buttock and posterior thigh. Sensory abnormalities in lumbar flexopathy. For the first picture shows us the anterior aspect, that is supplied by the intermediate cutaneous nerve of thigh, the medial thigh by the femoral branch of genitofemoral nerve. Medial cutaneous nerve of thigh supplies the medial part of the thigh, and it may extend down into the calf via the saphenous nerve. These are the sensory abnormalities for upper lumbosacral flexopathy, and these are sensory abnormalities for lower lumbosacral flexopathy. We'll move on to neuromuscular junction. I would like to discuss peripheral nerve and muscle in a separate lecture if possible, because this was too extensive and I have my practical exams day after tomorrow. Is it okay if I move on directly to neuromuscular junction?
Yes, that's fine. Yeah,
Yes,
you've covered
yes.
enough.
Ma'am, I just covered one short classification of peripheral nerve fibers: Group A, Group B, and Group C. That is on the basis of fiber diameter. The Group A fibers, afferent fibers are, and there are afferent fibers and efferent fibers. Efferent fibers are alpha, beta, and gamma. The alpha fibers supply the extrafusal muscle fibers, a fiber diameter of 17 mm. Beta fibers are fewer in number. They supply the extrafusal muscle and the muscle spindle, and gamma fibers supply the intrafusal muscles of the muscle spindle. A and B are myelinated muscle fibers, while C might be thinly myelinated or unmyelinated. Group B fibers are preganglionic autonomic. Group C are postganglionic autonomic, also for visceral and somatic afferents for pain and temperature sensations. Under afferent fibers, they give afferents from the muscle spindle endings, that is 1A, and Golgi tendon organ GTO, that is 1B. Group 2 are flower spray endings from muscle spindles, touch and pressure receptors, and Group 3 are for pain and temperature. This is for fast pain, Group 3, and Group C is for slow pain. Slow pain, burning pain, and the funicular pain sensations. Moving on to the neuromuscular junction. The neuromuscular junction consists of the terminal button of the synapse, the terminal button of the nerve end or nerve terminal or the dendrite, the motor end plate, and the neuromuscular junction in between. As we can see, the acetylcholine is stored in multiple vesicles, and it is released by voltage-gated calcium channels and voltage-gated calcium channels. The ACH release causes a change in the ion gradient in the neuromuscular junction, resulting in propagation of the impulse. The sequence of events goes as follows. Action potential comes to the motor, presynaptic terminal. Calcium enters via voltage-gated calcium channels, and it causes the efflux of acetylcholine from the vesicles to the synaptic space, and this calcium uptake into the terminal causes release of the neurotransmitter acetylcholine into the synaptic cleft. And ACH further travels across the synaptic cleft to the postsynaptic membrane, that is the motor end plate. The motor end plate contains nicotinic receptors for ACH, which are ligand-gated ion channels. It binds to the alpha subunits of nicotinic receptors and causes conformation change. When this change occurs, the central core of the channel is open and permeability of motor end plate to sodium and potassium increases. When the ion channel on the postsynaptic membrane opens, both sodium and potassium flow down the concentration gradient. And at resting, a potential net driving force for sodium is much greater than potassium. Hence, when acetylcholine triggers opening of these channels, more sodium moves inwards and then potassium upwards, resulting in depolarization of the end plate, which generates an end plate potential. This is not an action potential, but simply depolarization of the specialized motor end plate. As is the basis for RNS and neuromuscular disorders such as myasthenia and LEMS, a small quanta of ACH are released randomly from the nerve cell at rest, and there is a certain safety factor for the body which it maintains. When the safety factor is lost or the number of the synaptic vesicles decrease, it results in a neuromuscular weakness. To ensure a purposeful movement, muscle electrical response is turned off by acetylcholinesterase enzyme, which degrades the acetylcholine to choline and acetate. About 50% of choline is returned to the presynaptic terminal by sodium choline transporters to be reused for acetylcholine synthesis. In myasthenia gravis, not all ACH molecules can bind to the acetylcholine receptors, as well as antibodies to acetylcholine receptor, antibodies to agrin, antibodies to LRP, and antibodies to MuSK result in impaired neuromuscular transmission at the neuromuscular junction. This results in easy fatigability, weakness of the limb muscles or the axial muscles or the bulbar muscle. I would like to continue peripheral nerves and muscle in a second lecture if possible.
Yes, thank you, Dr. Ratnesh. Nandini ma'am, would you like to ask your questions?
Yes, you can proceed first, ma'am.
Anybody have any question they can ask?
So if it is okay, I can discuss the peripheral nerve and muscle after the 29th. So I'll have practicals on 29th. I'll be free on the 29th evenings.
Yeah, I think that will be good. Yeah, we can discuss once again this element part again.
Yes.
I think it's really vast and everything has to be, I mean, each and everything, like, we can detailedly discuss. The peripheral nerves, each peripheral nerve course, models, the tone, the other things, sites of
Yes.
lesions.
Yes.
But broadly, I think I have covered everything. It will be a little better if each thing is covered detailedly. Yeah, once it is done, your practicals are done, I think you can do it again.
Yes.
Yes,
Yeah, Dr. Ratnesh, when is your practical?
So 29th.
Okay. So
Yes.
29.
Yes, sir.
Okay, on Monday, we can keep one session.
Yes, sir.
Yeah. Anybody have any other question? They can ask. 31st, we can keep one session.
Okay.
Yes, sir.
Yeah. If there are no further questions, we will conclude the session. And thank you, Dr. Nandini and Yarna, for moderating this session. And thank you, Dr. Ratnesh. It was very vast inclusion of every point.
Excellent coverage of the topics. I think. Yeah.
Yeah, you have covered almost all the things. And tomorrow we will continue the examination and history and examination part of UMN and 11, and followed by case presentation. So we will continue. We will conclude this session. Thank you everyone
Thank you,
for
sir.
attending. We'll
Thank you, sir.
Thank you.
Thank you, sir.